Hormones are very, very powerful molecules. They change, especially the sex hormones. They change throughout the menstrual cycle. They definitely change during very different hormonal transitions. And it's just really fascinating to learn about them, how they function, and how they literally affect our everyday health.
Hi, I'm Joanne Stone. I'm the chair of the Department of OBGYN here at the Icahn School of Medicine at Mount Sinai. Welcome to our very first episode of HERology, which is a conversation podcast talking everything about women's health. So I want to introduce our co-host today. I'm Dr. Anna Barbieri.
I'm Anna Barbieri. I am a board-certified OBGYN physician and integrative medicine physician, and I love hormones. Hormones is what I truly love in medicine. I actually love all of medicine. I love women's health specifically. So I'll be sharing some of this with you and the audience.
And Dr. Leslee Shaw.
Thanks, Joanne, and it's really an honor for me to be here with you all today. I couldn't think of two other people that I'd rather be here with, and I direct the Blavatnik Institute, which is a research institute. We focus on women's health across the lifespan, and so we actually, and I don't think we love hormones, but we track them, and we track the stages of a woman's life, and we think that's really important.
Well, it's so great, and it's wonderful to have somebody that's such an amazing research scientist that's going to help us delve into understanding how hormones affect like cardiac disease and life, and such an amazing GYN who knows everything there is about hormones, and who, by the way, Anna, is my personal doctor, I have to say. I am a high-risk obstetrician, so hormones are involved with everything, obviously pregnancy, but maybe we can just start off by just telling everybody, what is a hormone? How would you define a hormone?
Sure. So actually, thinking back to medical school, it's so interesting because we kind of learned about hormones, but I really don't remember spending much time learning about women's hormones specifically. So let's start just going back to the basics and talking about what a hormone is.
Did we learn anything about women's health in medical school?
Some, but you know what I do? That's an aside. I do a lot of midlife women's health. And back then, and this has not changed, I just read the statistic literally last week, we still spend about 1 hour over 4 years of medical education on menopause. Okay, we have to change that. So we'll be covering that here in probably more than one episode. So everybody will get more than what medical students get typically. But I digress. Let's go back to what a hormone is. So basically, a hormone is a substance or a molecule that's made in one part of the body, but it can affect a lot of different body systems. And humans have many, many hormones. I mean, melatonin, cortisol, insulin, of course, are hormones. In women's health, a lot of people tend to think of hormones as our sex hormones. So, for example, the main sex hormones in women are estrogen, progesterone, but we also have testosterone. Some people don't realize that women have about 1/10 of testosterone that men have, but testosterone is an essential hormone. And there is a few other sex hormones kind of under this umbrella also of androgens. But hormones are very, very powerful molecules. They change, especially the sex hormones. They change throughout a menstrual cycle. They definitely change during very different hormonal transitions that many women go through. Puberty, pregnancy, menopause, and so on. And it's just really fascinating to learn about them, how they function, and how they literally affect our everyday health.
It's amazing, and it's true. I mean, hormones are released into the bloodstream, right, and can be targeted to different organ systems. So I guess we think of it just targeting our ovaries or our uterus, but it targets other things, right? I mean, 100%. The brain, the heart.
Yeah, I mean, the fat depots, as we all probably know, and blood pressure, and anything you can think of. I think particularly the menopausal transition throughout a woman's life, it's very noticeable how the loss of endogenous estrogen can impact weight gain, It can impact insulin resistance or perhaps the onset of diabetes. It can impact blood pressure and increase the incidence of hypertension. We go on and on and on. Estrogen in the brain, the loss of endogenous estrogen can cause cognitive issues. I mean, it's really pervasive. And so it's really shocking that the 10 years of a woman's life that she spends getting into menopause is covered in an hour. I certainly find that hard to believe that you can cover what happened to me during those 10 years in an hour. And that's incredible.
So wild. I think when I graduated medical school, I knew more about how to, describe the clotting cascade, which is how our blood clots with all those different, factors that have all those Roman numerals, then what happened to half the population as long as we made it into that age? It's pretty wild to think that.
It's totally wild. And what's wild also is it goes beyond, I think, just our education. I mean, growing up, I remember my mother lying in bed. I don't know, she must have been having hot sweats or something like that. And my father was just like, oh, she's okay. She's just going through something. Like nobody talked about it. Like the menopause word just didn't exist. I mean, I don't know if that was your experience, but certainly
I thought my mother was just crazy, but I was 26, she was 50. And, now that I have two daughters who are, in their late teens, early 20s, I would not be surprised if they thought the same thing of me. So I don't know how much has changed.
Yeah. I think it has. The conversation, though, has changed, right? I mean, we talk a lot about now I think there's a lot of people talking about menopause. Finally, it's becoming sort of like the hot topic to talk about. But I think, which is great, but I think people need to understand quite a bit more and understand some of the myths about hormone replacement therapy and what we can actually do to treat it. I mean, I know we're supposed to be talking about hormones, but I feel like that this is an important topic, right?
100%. Yeah, I agree.
Yeah.
I think that I think a lot of what is pushing us now within the clinical community, the medical community, is our patients who want to know, why do I have brain fog? Why am I getting this thing around my waist, it's getting bigger and bigger every year when I feel like I'm eating the same things. I mean, they are demanding answers. And we, as Anna said, we don't have a clinical community that is really that knowledgeable. And so it's really important. And I think menopausal hormone therapy is a great example how the clinical community is living 30 years ago. It's not kept up with the science. It's not kept up with the evidence. And that's why it's so important to seek out high-quality physicians like both of you and really get the real answers to how menopausal hormone therapy has its very, very positive impacts on a woman's health.
Yeah, well, here at HERology, we're going to be breaking down a lot of the myths, talking about a lot of the conditions. I mean, menopause is one of them, but covering so many different topics. But I wanted to go back to something that before we started this podcast, Anna had mentioned that she had a patient, or Leslie, you mentioned you talked to somebody who was 50 and said they didn't want to take hormones because it would give them cancer. And I think this all stemmed from research study that was done many years ago, and that really was not well done. Maybe you can speak a little bit to that and why there's such a difference now between giving hormone therapy safely as opposed to what people heard, the wrong information they heard years ago.
Sure. I think, Joanne, you're referencing the Women's Health Initiative that was published in 2022. And it was such a landmark study. And when it came out, I think many of us specifically in the women's health and OBGYN community remember even where we were, because overnight it changed practice patterns. I was still a resident. I was in labor and delivery. It was 2002. I'm sorry. I was going to say 2002. Yeah, it's a long time ago. I was a resident a long time ago. So it was 2002. And I remember where I was, and it was such a shocking conclusion that literally changed things overnight. So just to describe the study, this is a very large randomized controlled trial, which is really the gold standard of medical evidence and how we decide whether a therapy is worth it, whether it works or not. And what this trial aimed to do was actually test the theory that using hormone therapy in menopause reduced cardiovascular risk. So what happened is that many, many women were enrolled across many institutions, and a group of them was given both estrogen and a progestin in a certain form, in a type of hormone therapy that's really not used very frequently anymore. It was a combination oral therapy of synthetic hormones. The estrogen was called Premarin, and there was a progestogen called NPA. And another group of women who did not have a uterus because of a previous hysterectomy, they just received the estrogenic part. And then the study was stopped prematurely because it was noted that the women in the group who received both had an higher than anticipated incidence of diagnosis of breast cancer. And this was published, actually, the media published it before proper peer review was done. And all we needed was just an overnight headline that hormones cause breast cancer. And that led to essentially an overnight 80% reduction in hormone therapy prescriptions. And widespread fear set in, both among women, but also among physicians and practitioners, because I can't prescribe it in case somebody gets breast cancer. What if it really does that? What if it's not related, but someone blames me? Plus, hormones are difficult to talk about. It's a big topic in our current medical system. We could run a whole different series of, podcast sessions on this. People get 10, 15 minutes per visit. It's difficult to cover the nuances of hormone therapy. So what that study did is really resulted in a 20-plus year consequence of both women being afraid of hormones and providers being afraid of hormones. Now we do have more data that has come out, and I think the conversation is really changing around this topic, driven a lot by women and the public themselves. I look at it as this massive kind of grassroots organizing, which is great. And I do think it's about time for the medical providers and the medical establishment to get behind it, because we do have better data now. We do know more about what hormones may be more optimal, when to start them, and certainly menopause hormone therapy is being used more and more frequently now, but we still need to do a lot more in terms of education and the provision of the right regimens. Hormone therapy for menopause, and by the way, a lot of people say HRT. HRT is being rebranded to HT or MHT. Certainly, the proper terminology now is menopause hormone therapy to differentiate it from true hormone replacement therapy that we would use, for example, for somebody in premature menopause and restore their hormones completely to a premenopausal level. I think for this podcast, if HRT slips out of our mouth, most of the time we mean really MHT or 100%. Menopausal hormone therapy. It's an intervention like any other one. So I do think it's so important to have a conversation with each patient about where they are in their perimenopausal or menopausal journey, what symptoms they have, what does their totality of their health look like, and what they can expect out of the use of menopause hormone therapy in their case. And that covers risks, that covers benefits, that covers side effects. To me, it's no different than talking about any other medication or scheduling somebody for surgery. It has to be a nuanced, well-discussed and individual decision.
So I wanted to, this really great point, I wanted to bring it back to something that you mentioned before. We talked a little bit about testosterone, right? That one of the things I don't think I learned that, that we make testosterone, or always make testosterone. And, of course, at much lower levels than men do. So testosterone is being used for some women who have, libido issues, some sexual, not libido issues because they hate the husband or partner or whatever, but, who truly have an issue with it. And it's being used to help supplement that and improve their sexual life, really, sexual health. But it's not a replacement, right? It's not to replace it to physiologic levels. Is that correct?
Um, Almost. When we do replace testosterone, and just to be clear, maybe we'll go back and talk a little bit about what happens to testosterone, because the patterns of changing testosterone levels are a little bit different from the patterns of estrogen and progesterone. Testosterone basically peaks in our early 20s, and then it's kind of steadily goes down. And while we know the range of testosterone for premenopausal women, it's actually very difficult to find in the literature what the normal level is for somebody who is 55. And we never measure it before. This is part of kind of my interest in advocacy. I actually think we should have an idea of what someone's hormonal picture looks like when they're completely premenopausal, when they're feeling well, before they start the process. So if it comes to kind of targeting, especially with testosterone, an optimal level for that individual, we know where we're going. But typically, testosterone is used, and this is consistent with all the guidelines, for treatment of hyperactive sexual desire disorder, which is low libido. And of course, low libido, this is such a big topic. Testosterone is not going to fix a toxic relationship. Testosterone is not going to fix somebody's overworked schedule when that has to do with it. But it can definitely be used for that and can be used quite safely. So we use it quite a bit. And I think we should expand both awareness and education of providers how to use it safely, and lobby for more research. Currently, there is no FDA-approved testosterone for women. There is more than 10 products that are available for men. So we actually used male products adjusted for female dosing. But this is something hopefully, we'll see some changes over the next few years.
Do you prescribe, because there are some lifestyle things which will increase testosterone. Now, I don't think substantially. Actually, another part of the research is I don't know. But eating certain foods will increase testosterone. Strength training will increase. Exercise will increase. Do you also include that?
I think lifestyle in general is just massively important when it comes to hormonal health. And I don't think we can separate those two. Your lifestyle will impact your hormones. Your hormones will impact what you perceive your kind of general wellness to be. They go hand in hand.
Yeah.
Same is true for testosterone. Some activities may improve testosterone somewhat. Strength training, for example, adequate protein intake. There are certain botanicals that are touted as testosterone increasers. I don't know if that's a word. Probably not.
It's a new word.
We'll take it.
You heard it here first.
Yeah.
They are not that great, and they can have a lot of interactions, both with medications that can have impact on your liver function tests. I tend to not recommend supplements for testosterone increase. But yes, strength training and protein intake are going to be the two sort of big factors there.
It's interesting. You mentioned advocacy, but I was trying to, as you were chatting, I was trying to think of when that little blue pill Viagra came to the market, and how it's only now, and it must be out 20, 25, 30 years. It's been a while for erectile dysfunction in men. But now we're still just talking about some of these issues that are relevant to women. It's okay for women to want to have a happy life, right? And I think that's being very much the advocate for your own happiness and your own health is really what we're asking women to do in this podcast, isn't it? I mean, we really want people just to knock on the doors, find the right doctors, do the right things, and become healthy and live a healthy life throughout their entire life. That would be awesome.
And learn the truth, right? Learn the truth about women's health, and not just, what they're reading and what they're seeing on social media, things like that. I think it's so important. I remember when oxytocin, which is a hormone that, as an obstetrician, we think about oxytocin during labor, helping to give contractions and being involved with breastfeeding, things like that. But it came out, I don't know, years ago that it was like the love hormone, but the truth is, it does have certain effects. It goes into the bloodstream, it goes into the brain, and does have some effects on empathy, on bonding, either whether it's your baby or another individual, has some stress reduction. So it's really fascinating to learn about some of these hormones and how else they're being used.
I actually don't think even as a practicing OBGYN, before I delved into the world of hormones, kind of in the second chapter of my own medical practice and my own career, we don't realize how wide-ranging these effects are across the different stages. Just to realize that the women, for example, who may have premenstrual depression or premenstrual dysphoric disorder may be at higher risk for postpartum depression. And that's going to be the same group that may be at higher risk for depression and anxiety related to the perimenopausal transition. We don't understand what it is about the brains and the minds of that group that makes them susceptible. One of the newer drugs for postpartum depression is really an analog of the hormone progesterone. That is so fascinating, and how quickly it works, because perhaps postpartum depression, at least in some cases, is related to this hormonal cliff that we fall off at delivery. And it opens up the door to how much more work there is to be done in this field. It opens up the door to all these different possibilities. And it also opens up the door to, Leslie, what you said, and Joanne, you too, about the conversation about how important it is to know this, to advocate for ourselves, and what it is really to define the worth of a woman and her health. And that is important across the lifespan.
It's interesting. I'm going to do a little Mount Sinai commercial, right? And the three of us have really been leaders at Mount Sinai in organizing clinical care for women, targeted care, pathways of care, which is unique across almost any health system that I can think of. And, as a leading clinical researcher, I've been to a lot of these places and I know what they do. But it's interesting if you think about the group of folks that we have. As you were chatting, both of you, I was thinking about our psychiatrist colleagues who are studying estrogen in the brain. That's so unique. Our neurologists who are studying the impact on women's health on Alzheimer's disease. I mean, this and cardiovascular disease, which is my area, we do a ton of work on that. Metabolism, obesity, et cetera. I don't know any other institution, certainly across New York City, that has you both and has a bunch of other folks that are so passionate about women's health. I just think we have such a great opportunity, really, to revolutionize women's health and create new standards that I think are just going to be fun for me to engage with both of you, because I think that's just my commercial.
Yeah.
I'm sticking with it.
No, I thank you for saying that and for being part of this, right? And being part of the change that we're gonna be making. I mean, so I'll just say, we're going to be opening up a center, the Callan Rowan Center for Women's Health and Wellness, which is going to be entirely focused on this, on the clinical pathways that you mentioned, on how we prevent disease and not just go ahead and treat disease, right? I mean, it's striking to me to hear, we had a symposium last year, and Lisa Glatz, who's the chair of orthopedics, gave a talk, and she started talking about how, we lose bone health starting at age 30. I didn't know that. I never learned that in medical school. I told my 30-year-old, you need to start, my 29-year-old, you need to start exercise. Who doesn't exercise? You need to start exercising because you're going to lose bone health. It made me crazy. I started taking creatine and working with a trainer. I mean, but these things you mentioned before, lifestyle, these things are so important, and we want to work on prevention. And that's what the center will be about.
I think it's just super exciting to be in on a team that's proactive and not reactive. And also a team that sees a bigger picture, health and healthcare in general. And we see that particularly when women's health is so fragmented. I'll tell you, when I went into perimenopause in my early 40s, as a busy obstetrician, I actually had no idea what was happening to me. One day I forgot the number to my medical license, so I run to a neurologist thinking I had a brain tumor. That was my primary thing on my differential. which I did not have. But that's where it ended. And he said to me, he actually gave me good advice, which I did not follow. And that is to do a little bit less in my day because I was under too much stress and I probably would have felt better had I followed his advice. But it was perimenopause related. And, a women's health doctor, an OBGYN, did not know, did not realize it myself, seeked care from a specialty that wasn't really the primary sort of root cause specialty for what was happened to me. And that was it. And we see it all the time. Women are going to the cardiologist, the psychiatrist, the neurologist, and often no one is connecting those dots. So sitting here with both of you, it's just so much fun to be connecting the dots.
That's awesome.
Yeah, definitely.
When I applied for this job a few years ago, I was at another New York place. We're not going to talk about that. But I said my biggest pet peeve about healthcare are the silos that aren't connecting these dots and how much inefficiency in care. And you go through pregnancy and we leave it behind you. It's never mentioned again. It might be mentioned by some doc, but rarely is it ever mentioned. If you have high blood pressure during pregnancy or you have diabetes during pregnancy, it's never mentioned again. It's just left behind you. Whatever happens in your 40s is left behind as you enter your 50s. That's just flat out stupid. And we are a being that evolves over time. Our health evolves over time. But I think from what I see across a woman's life is every stage of life is an opportunity to embark on a new way of life, one more centered around prevention. And even if it's small increments, all of those increments are going to be better. I'm a huge fan of prevention. I've done a lot of preventive research. And, there's this new way of thinking in prevention, which seems so obvious and which is oftentimes the things in medicine that, they come across and they hit you across the face like, how come you didn't see that before? That seems so obvious. But it's that we need pathways of early detection. We need pathways to understand early signs of diabetes, early signs of high blood pressure, early signs of obesity, and we need to understand the genetics of these conditions. I think we're going to be embarking on a lot of different really novel research approaches to really unfold a really novel approach to understanding how a genetic proclivity to obesity can actually change that woman's life across when she gains weight during pregnancy, when she gains weight during menopause. We have a lot to learn. And I think we're really, fingers crossed, knocking on wood, whatever superstition you have, that's because I'm Irish, is we have a lot to learn and, hopefully we'll find a lot of answers. It'd be cool.
I want to go back to something. You mentioned progesterone. You mentioned like the drop in progesterone and postpartum depression. Progesterone is a fascinating hormone. I mean, it has anti-inflammatory effects. It's important in pregnancy, right? In early pregnancy for implantation. A lot of our reproductive endocrinologists who treat patients who have infertility and have IVF put them on progesterone early on. It's also used, it's a little controversial whether it helps with patient with prior miscarriage. It seems that some data suggests if you've had several miscarriages, it might be helpful. We know, I just saw a patient today actually who, I don't know, her last pregnancy, she had full-term delivery, a scheduled C-section for a breech where the butt is down. And I just scanned her today at 20 weeks and her cervix is short. And I'm like, why? Like, what is going on here? And so there is evidence to show that in a patient without a prior preterm delivery with a short cervix, that giving progesterone vaginally can help reduce the risk of delivering prematurely. So I just prescribed that. But, progesterone, what else do you think about progesterone? How else?
Progesterone is a hormone, so by definition, it's going to have these multitude of actions. And traditionally, and this was even the case when I trained, OBGYN, and Leslie, I think I have you to thank for this term, was considered a bikini medicine, meaning OBGYN was just about what happens in your bikini.
Stop.
I don't know. Well,
I'll take credit. I should take credit.
That, OBGYN was really about your uterus and your ovaries, maybe your vagina, your vulva, and that's it. So, and because those parts were involved in pregnancy, then we did obstetrics and only those kind of the hardware, had some sort of a condition like fibroids, we could remove the uterus. But OBGYN is such a wide field. And because those anatomical structures make hormones, really the field of OBGYN is expansive. And progesterone is a part of that. So as a hormone, progesterone, of course, is made by the ovary. It's typically made only after ovulation. So without ovulation, we're not making progesterone. Progesterone is necessary to support the development of a very early pregnancy and support the maintenance of a pregnancy, actually. And then progesterone falls off a cliff at delivery. Progesterone also falls a few days before a menstrual period. And this is something that I would love everybody to learn from this. When we have a normal period, that is a bleed that happens in response to falling progesterone levels. And there's estrogen associated with that, but a normal period happens due to falling progesterone. And even a period on a birth control pill happens because we stop taking an active pill that has a progesterone-like substance in that. And then progesterone falls gradually across the perimenopausal transition, which can be actually take forever because it can be a decade. And progesterone tends to fall first, ahead of estrogen falling. So I see many, many women who come to see us in that very early phase of perimenopause where most of their symptoms may be related to low progesterone, shorter cycle, heavier bleeding, insomnia. I don't know if anybody other has woken up at 3 a.m. That very well may be actually falling progesterone. Heightened anxiety and a sense of overwhelm. And I don't want to be too simplistic and just say it's only progesterone, but oftentimes it is. And it's actually one of the theories behind premenstrual depression. We're not quite clear whether that is due to falling progesterone, whether that is due to sensitivity to progesterone, whether that is due to falling estrogen. Lots of things to work out. And the other fascinating thing is that although we all have these hormones, we're very individual when it comes to how they interplay in each person, what our sensitivity is, what our side effects may be when we start using them. Some patients have a tremendous sensitivity to progesterone, and within 2 days, they know they cannot take it. They are super depressed. Their mood is off the wall. And some people love it, and they think it's sort of like a nightly glass of wine because it helps them sleep. It makes them relax. It's great. And of course, progesterone is used in hormone therapy regimens. One of its main actions is to prevent complications of estrogen use on the uterus. And it gets a little bit technical, so maybe we can cover that another time. But very important part of hormone regimens.
Yeah. I mean, I think it's a hormone that we're going to see, getting researched much more, and its use being more ubiquitous for a whole variety of different things. I mean, very interesting that the and I'm skipping my name now. The
Makina?
No, the postpartum depression medication that's progesterone.
Yes.
Yeah, very, very fascinating that it's analog. So yeah. One of the funny facts, you mentioned Premarin, and I mean, I haven't even thought of that term.
It's a long time, right?
So long, right?
I have to say this because it's so interesting.
Yeah.
Premarin is the first estrogen that made it to market in 1942. So it's been on the market for almost 100 years, and it's still available.
Premarin.
Yes.
Mm.
Yeah,
and that came from that. The name is because it came from, isn't the urine of cows? Wasn't that how it was?
Horses. Yeah. Equine, conjugated equine estrogen.
Premarin, so it's pregnant mares. Yes, that's how it was isolated.
Yeah.
Interesting.
Well, I didn't know the difference between cows and horses. You can tell I'm a city girl.
Whatever. Well, I grew up in the city, so I saw a cow for the first time when I was 8. Besides on TV. I saw it on TV, I think. But yeah. But I think that what's really cool is Anna loves hormones, right? She's never going to forget that, right? I'm going to introduce her when we go to seminars for the woman who loves hormones.
Love hormones, yeah.
No, but what I always am reminded when both of you speak, I mean, hormones have such a all-encompassing impact on many, many organ systems, right? Many, and it's quite diverse. And that's where I think obstetrical and gynecologic care are really at the heart of the point of care for women. And I know you guys believe that, but, I think outside of this room, there are others that don't believe. They feel other, maybe generalists or whatever. But I do think that it's really that knowledge is fundamental to care of women as they age, and how we can actually bring that knowledge in on any stage of life, really, to optimal care of women. It gets pretty daunting, though. I mean, you guys are amazing, but you're really caring for comprehensive needs of women, and from obesity, whatever. We can go down the list, and especially as they get aged, all of these factors come to play in a very dominant manner in the postmenopausal woman. But it's pretty daunting to know all of that, And I wonder, though, if we should ask Anna to kind of go through what is integrative medicine besides, hormone. I mean, when I know and I mentioned that we have several physicians who will be certified in integrative medicine. Is that right? Certified or specialized? Mm-hmm. Either way. That people go, well, what does that mean? I think people would like to know.
Yeah, definitely, because I think there's a little misconception about what it is, and so you want to describe?
Sure. So I think, when people hear this word integrative medicine, it brings to mind maybe a mortar and pestle and taking some sort of herb and grinding it up. And, as we go on, you'll hear me.
We've seen you do that in your office, though.
I don't know what she's grinding, but it's not hormones, I don't think.
My husband is going to be like, wait, you did give me that last night. And it's not really what it is. I mean, integrative medicine does encompass the use of a variety of different therapeutic tools, ranging from lifestyles. So we're going to have stress management techniques like meditation, for example, yoga, nutrition, movement, exercise. Yes, through the use of some botanicals and supplements. And it's a whole other episode where we can talk about their quality, what's evidence-based, what's not, but also the use of pharmacologic solutions and surgery. So it's really a pretty wide berth of the different tools. But integrative medicine is more than that. It also assumes that we are treating a patient as a whole person. That person cannot be reduced to a single symptom or to even one hormone. It means that we have to connect that person's physical and emotional health and even spiritual health, that no person exists without the community that they exist in, because that was going to exert effects on their health. And integrative care also means that we're working as a team and connecting those dots. So I think here, at the center, we are going to practice that, across all the different levels of integration.
Yeah, I mean, I love the way you said that. And I think, yes, there is definitely that component of lifestyle, of foods, of supplements, things like that. But as you said, it's also really thinking about the person as a whole, where they meet them where they're at, understand where they're coming from, whether it is some spiritual, whether they're the type of person that, wants you to tell them what to do or make the decision themselves after doing, 3 weeks of research and coming to a decision. I mean, I had several different patients today who I had a medical student with me, and a few of them were like, just tell me what to do. Like one of them, like the baby is measuring 9 pounds, 13 ounces. And, should she try to deliver vaginally, or should she have a section? She's like, and some people, you have to understand, do you want to give them information that you decide, which is typically what, or she's like, no, I really want to know what you would tell your daughter, to do. Or somebody else is deciding on an invasive test that could have minimal risks to it. Tell me what to do. And then the other people, so you have to think of the person as a whole. And I think we do that, not, there's integrated medicine, but there's also that perspective about caring for the whole patient, who they are, making sure they're comfortable with the decisions that they make for their own health.
And, I think we come across these labels: integrative medicine, functional medicine, Western medicine, Eastern medicine. To me, it's actually good medicine is good medicine. It takes all kind of evidence-based therapies into account and treats that patient as a whole individual. I think you bring up a great topic, actually, that maybe we should cover, and that is, how do we talk with our patients, and how do we, because we have been patients too, so we know it from both sides of, of this relationship. How do we help people make these decisions? For a long time, it used to be that doctors told patients what to do. Then it was, no, we can't tell anybody what to do. Here's the menu of options, and you pick. I'm staying out of it. You pick. I'll just tell you that it's A, B, or C. I think that it's probably somewhere in the middle is the right thing, and that can only be arrived at after getting to know somebody and really kind of joining them on that journey.
So, Leslee, let me ask you. We talked about the study that had
Women's Health Initiative,
yeah, the Women's Health Initiative, I know that there are women out there that are like between 60 and 80, and they missed having hormone replacement therapy. MHT, sorry, menopause.
Word, please.
Yeah, thank you.
All doc new tricks.
Yeah. And so, and they missed it, right? And they're saying, well,
Why is she looking at me when she says that?
No, I'm thinking about some older friends who sort of missed that era of taking hormones, and they're like, well, what do we do now? But I'm curious. Those are the people that really were stuck with this myth, or not myth, misinformation really about that study. So can you just briefly state what was the big factors that related to that dispelling the misinformation?
Well, it led to a lot of clinical practice guideline indications for harm. And that's a really strong statement from medical societies. So almost any prevention guideline that you can think of had a class 3 indication, which is a contraindication due to harm of the use of menopausal hormone therapy, although they still call it HRT. They don't call it menopausal hormone therapy. So if you think about that, and any area of prevention, you think of prevention typically in a general medicine setting would be cardiovascular care, metabolic care, endocrine care, all contraindications. And that was for 20 years. And there's still contraindications. And the trial implications said you wouldn't give menopausal hormone therapy for the prevention of cardiovascular disease. That's the take-home message from that. And so now, if you're thinking about a lifestyle of prevention, one of your goals would be not to have cardiovascular disease. It's very common in many, many shapes, forms. And so if you don't get to optimize your health with the use of a non-oral route of administration of menopausal hormone therapies, you're really left with not optimizing your health. And that is really a falsehood, because the trial results didn't show that. So I have been in I don't know how many meetings debating people about menopausal hormone therapy. Even somebody from the Cleveland Clinic on a conference call last night who said to me, that still should stay. And I said, I would take it just a little bit differently and say you need to have, if you have risk factors for coronary disease, you have high blood pressure, lipids, high cholesterol, you need to have a discussion about risks and benefits. If your blood pressure is not controlled, you maybe want to have that discussion. But so there still are some caveats that I think I would put into that. But still, you have to have those discussions. I'm having issues of cognition or brain fog, whatever you want to call it. You need to talk to your clinician, or other types of vasomotor symptoms, hot flashes or whatever. Have the discussion. Have the discussion about the risks and benefits. Break through that misunderstanding. Push your doctor. I can easily say it in front of the two of you, but you need to push your doctor to get up with the evidence, and that non-oral administrations are totally different than the oral forms, and they need to get up with 2025.
Well, thank you for trying to summarize that so quickly. And again, we couldn't just have a whole other episode on HERology.
And we will, because it's so important to talk about hormone therapy in a really comprehensive and nuanced way. And I totally agree. And, the current guidelines say that hormone therapy should not be used for prevention of chronic disease. That is what they say.
But also it says harm, too, which is incorrect.
And I think we need to really bring to light the research that says otherwise, and continue the conversation around it. And I think another, just aspect of this that complicates things, we tend to ask a lot of simple cause and effect questions. And take someone in late perimenopause who has joint pain, who is fatigued because of this hormonal changes, who now stops moving and exercising. You're not only removing the protective effects of estrogen, now you're taking away some of their ability to engage in hopefully daily movement that's going to go a long way towards prevention in the future. So I think it's really, maybe that's what AI can help us with. How do we connect all of these, so many different dots around these questions?
So we have a lot of app development here at Sinai. It's going to solve that problem. Patients just going to have their smartphone. They're going to have their little app in there, and it's going to tell them, you need to get up and
Nobel
walk.
Prize.
Get up and walk. You need to walk. Go walk around the block. Being functionally capable is the number one goal, should be for every patient that we see.
Yeah. I mean, we talk a lot about, increasing, longevity, but it's the health span, right? It's living life.
Just get dogs, everyone. Just get a dog.
Get a dog.
Or two.
Two.
I haven't have a baby. So, yeah. So before we wrap up this episode of HERology, which you can find on Spotify, on Apple Podcasts, wherever you get on the Mount Sinai website, I just want to end with a final question to you guys. What one thing do you wish you knew 10 years ago that you know today?
Well, I think that, your body changes, right? And, I also have, I have bad knees because I exercised a ton when I was a kid.
You were an athlete.
I was a big athlete. I was All-American and all that. My knees are trashed. But what I know now is that life is a continuum of stages, and at every stage I have to refocus and reset goals. And like you said, that woman who just gives up, I can't be that woman who just gives up and is happy with my health. I can't just get 8,000 steps. I've got to get 12 or 15,000 steps. And I go on the bridle path around the lake in Central Park because it's dirt and it's not concrete. So you have to pivot. I think that's the best thing I've learned, is to adapt and pivot and take it to the next step. Because you know what? You don't know how much you're capable of doing until you try.
I love that. Bridle paths. I'll be on that with you. Anna, what about you?
You know what? Mine maybe is similar because I feel much older and wiser than I was 10 years ago. And I think, sitting here at this age, I think that we're best when we appreciate and acknowledge our past, really live in the present, and have plans and look forward to the future, rather than constantly analyze what happened before or struggle somehow to get back to our 25-year-old self. That's not going to happen. And we forgo the opportunities of the moment and what we can accomplish, achieve, and enjoy in the future. And I know it sounds very non-medical, but it's such a truth that I think if we remember that every day, our health will get better because of that.
Yeah, definitely.
Okay, you're next.
Okay. I mean, I knew everything. No, just kidding. I think that maybe just to be able to focus a little bit more on myself and the things that make me happy, and doing things that will keep me healthy. I think I've only started to exercise more in the last few years, and that's been really life-changing. I mean, doing strength training, Pilates, walking, getting the steps in. I didn't know that back then, and I wish I had. I would be in better shape. But that's what we're here to discuss on HERology. This has been an amazing, hour. It seems like I can sit here talking to you guys forever.
Part 1.
Yeah, part 1. So stay tuned. Follow us on YouTube. Find us on Spotify. HERology. We're here for you.